Dr. Grubb, what is the follow-up regimen of the therapy that these patients have to follow? Are there any precautions the children and parents have to keep in mind during recovery and going forward?
Well, so I think that you can sort of break this up into getting ready for the therapy, receiving the therapy, and then what does the long term look like. And so from a getting ready standpoint, we're working with the doctors at the hospital where the patient is treated to make sure that the patient gets an appropriate amount of leukemia therapy without being so intensively treated that they get sick from their prior therapy and we can never treat them. So that's one precaution that we take. During the month after the cells go in, we like to keep the patients close by, and we're treating patients from all over the country and actually all over the world. And so we do ask the families to stay in the Philadelphia area for 3 or 4 weeks after the cells go in. And so during that period, we're looking for cytokine release syndrome. That's our big thing, and it's easy to pick up because if you have a fever, that's the start. You can just stay with a fever, or you can get sicker like Emily did, and it depends very much on how uncontrolled your leukemia is. So most of these patients are admitted to the hospital for a short period of time, and 20-30% of them actually end up needing ICU-level care for a week or less. And so that is the sort of what happens right after you get the cells. Now, what's amazing to me, these are kids. Underneath their cancer, they're still healthy. And so all you have to do with kids like this, and we saw this with Emily, is leave them alone. And you're not giving them treatment after treatment after treatment. You're not keeping them in the hospital all the time for high-dose chemotherapy. You're not causing them to get infections because their white cells and immune systems don't work anymore because of the chemotherapy. So they get better so fast after that initial 3 to 4 week period where we're watching for potential side effects. And there, the precautions are minimal. I mean, we're pushing these kids, and of course the parents are pushing harder than we are, to get back to school as quick as possible. We want to get them back to their lives. The one long-term side effect we absolutely do see, and I don't want to minimize this, is that the kind of leukemia that we're treating is related to normal cells in your body called B cells, and B cells produce antibodies, and antibodies are basically what vaccines make for you. And if you don't have normal B cells, you don't make antibodies, you don't have that vaccine-like protection, and you need to get a medication to replace that, which Emily and a lot of the patients do get. So if they get that medication, I think, and Tom can confirm this for me, I think that basically we don't see a lot of problems associated with that, and that's really the only long-term side effect that we've seen in these patients.
So Tom, as a parent, what are some of the precautions you keep in mind when she is probably off to school or to play?
Well, I think, we look at her now as a normal child. It's just minus B cells. So as cancer parents, Carrie and I still panic inside if somebody's really sick around her. But I think anybody that sees somebody that has something contagious is going to try to keep their child away from them. But we don't have to limit whatever she wants to do, she can do, minus being around somebody that's got a severe virus or whatever. But I think any parent would do that. So I can't say that, now we still worry a lot as parents because we don't know what's going to happen tomorrow, but she's a normal child.
So does she have a favorite game or sport that she likes to play?
Well, she's on her computer quite a bit now playing Sims, and she likes to do Minecraft. She has a lot of architectural skills for Minecraft.
Okay, that's nice to know, Dr. Grupp. Moving on to the cost, as I was mentioning right at the beginning, and the high cost of CAR T cell treatment has been a shocker for many. At $480,000, the affordability of this treatment has come under a lot of fire. So it would be great to just hear your views on this.
Well, that's a very important consideration. Obviously I'm a pediatrician at a hospital in Philadelphia. I'm not a drug company person. But what the discussion about the price of CAR T cells has really brought forward, in my own personal mind, is medicine in America is incredibly expensive. Being in the hospital is expensive. Cancer drugs are expensive. The cost of this particular therapy, Kymriah, or it has another name which is nearly unpronounceable, which is tisagenlecleucel. The cost of that is very comparable to a lot of the brand new cancer drugs that are available these days. And the reason why it is a little bit more striking, for sure, is that instead of being a therapy that you get every month and it costs you $20,000 a month, but you could be on it for years, this is a therapy you just get once. Emily got these cells once. And so the concept that for at least some of the patients, not all of them by any means, but a big fraction of the patients, this can be one and done. This is a one-time therapy. I mean, literally, although the side effects can be significant, as we've talked about, the administration of this therapy takes 2 minutes. You walk into the door with a syringe, you infuse it into the patient in a very short period of time, and that has the potential to be the last treatment the patient ever gets. And so from our perspective, we worry about access. We want to know, will insurance companies pay for this? And in our experience, having given more commercial CAR T-cell product than any other hospital in the country right now, is that insurers do pay for this. So that's extremely important. If we can't get an insurance company to pay for it, then we can't give it to the patient, and that's a significant problem. So we want to make sure that the kids can actually get this. And then the issue of why medications in America are as expensive as they are, broadly speaking, that's a societal question I'm not really prepared to have a good answer for. But do I feel like in this particular instance, this therapy offers significant value to patients, not just a marginal increase in potential months of life, but potentially being a cure for a reasonable fraction of patients? I think it does offer significant value.
Thank you for sharing that, Dr. Grupp. We'll have a couple of questions on the therapy and the trial as such, and then we'll hand it over to the panel for some questions. So Tom, I'll start with you. We want to know, where did you first hear of the CAR-T trial, and what prompted you to make the final decision to enroll Emily in an experimental drug trial?
So we actually found the trial on our own. My wife, Carrie, works in research at the Penn State University, so she used her research skills to look at any available possible options, and it really made us happy that there was something available that's only 4 hours from our house. I know at one point I told Emily, if I have to crawl to the North Pole to get you better, I'll do that. But we did not get support from our local hospital on going to an experimental trial, but we did it on our own, and we trusted our instincts as parents. And transferring Emily down into Dr. Grupp's care was the best decision we've ever made. So when by the time we had transferred down, our options were take Emily home on hospice, or transfer down to the Children's Hospital of Philadelphia and try her as a first patient in a phase 1 trial. And we weren't ready to stop fighting, and Emily wasn't ready to stop fighting, so hospice wasn't an option for us. And I can tell you as a parent that deciding to join this trial for me was easier than trying to give Emily full body radiation to go to a bone marrow transplant, because that scared me more than this trial did. Worrying about doing permanent damage to her learning ability and everything with the radiation. And, I think we were almost going to bone marrow transplant, and in the end, the CAR-T treatment cost much less for our insurance than the T-cell treatment did.
Mm-hmm. Yeah.
So for us, it was a life and death decision.
Yes. Dr. Grupp, I know you talked a bit about what the therapy entails, but as we are talking about children here, so does trials for children have any specific considerations that you have to make?
Oh yeah, there are definitely significant considerations that we have to make, and the most important one is that when we set up a clinical trial for kids, for especially a new medicine that's not been tried before, we really have to ask the question: do we think it might help? If we feel like that, they call this prospect for benefit. Do they feel like this might actually be helpful? There's no guarantee of success in anything that you do in life, but is there a reasonable chance that the child who is in front of you will benefit from the therapy that you're offering them? And if you can basically convince the Food and Drug Administration and the Ethics Review Board at your hospital that you have data that shows that there might be a hope for that individual child, then that's really when you can include patients in research. And obviously, for patients who have much less serious conditions, that's a pretty high bar to get over. But in patients who have cancer and no other treatment options, the bar becomes a little bit lower because, as Tom pointed out, for many of the patients that we treat, it's either this or care intended to make the patient comfortable in the last few weeks of their life. And so that's a very stark decision. That said, from my perspective, I'm a pediatric oncology researcher. I've been doing this for a long time, but facing a family like the Whiteheads and saying this is a brand new therapy, it's only been tried in a small handful of adults. Nobody has ever really treated cancer with something like this, exactly like this before. It's never been tried in a child before. It's never been tried in a patient with this kind of leukemia before. I mean, that's a lot of nevers. And so while we were very hopeful that it might provide some benefit for Emily and could not have done that without that, the courage involved of the family to get involved in this kind of research, I think, is also extremely important. So yes, we have a special requirement in pediatrics that we feel like the research is worth doing.
Yes, I have one last question before I hand it over to Gary Peterson. CAR T-cell is a living drug and it's supposed to remain in the body for months and years fighting cancer. So apparently, in some patients, the T-cells go away quickly. Dr. Grupp, do we know why this happens? And if the CAR T-cells go away from the body, will the cancer recur?
So there are lots of pieces to this. So let me try to sort of take that apart a little bit. So the answer is that with this particular CAR T-cell therapy, the recipe seems to be that the vast majority of the patients keep their T-cells for months and years. I mean, Emily still has those reprogrammed T-cells in her body. And a lot of the patients who are 4, 5, 6, even 7 years out do. And so that's a large number of patients. But there are patients who, 20% or less, who lose their cells within a few months instead of keeping them for many years. And then there are other kinds of CAR T-cell therapy that don't last nearly as long, that last 4, 5, 6 weeks, and then the cells are gone. And so we're just now figuring out lots of things. So the first question is, can you give the cells again if the effect wanes and you want to protect the patient for a little bit longer? And the answer is yes, you can. And we've done that in patients who have lost the cells quicker than we would like. So you can totally repeat the treatment safely in these patients. When you repeat the treatment under these circumstances, they don't have leukemia. All right, you're just trying to protect them, and there the side effects are nearly zero. It's a whole different experience for these patients. So repeating the treatment it doesn't have significant risks associated with it at all. And then the other question you asked me is, how come Emily has her cells for all these years and other patients might only have their cells for a few months? And that's an area of really intensive research. We want to understand why T cells behave the way they do. Remember that this is not a drug where everybody gets the exact same thing, right? We're making this quote-unquote drug or this treatment out of the patient's very own T cells, and we're starting with the T cells that they have. And so what are the characteristics of these T cells that make them last longer and go the distance? Some people have marathon T cells, and some people have sprint T cells, and they go away a lot quicker. And that actually is one of the major areas of research focus in my own personal lab, and especially Dr. Barrett, who has been supported by the Emily Whitehead Foundation as well, is looking at these questions of why do T cells behave the way they do. But the short answer is we don't know. We have a lot to learn because this is a brand new field of medicine.